all over the globe. And our model is a collaborative partnership model for research and development. And our headquarters is in Geneva, but we have offices scattered all over the world. We have an office in New York, in Latin America, in Africa we have 3 offices, in Cape Town, in DRC, Congo, Nairobi, and then we have Delhi, Japan, and Malaysia. And so we have a lot of partners. We work with partners. We never ever work alone, because in a neglected area like this, you need all the expertise that you can have, so that you can speed up the process. Drug development is not easy and takes a lot of time and resources. So if we can work together, and that's our model, work together with partners, especially in low middle income countries, and our partners such as pharmaceutical industries. We work very well with the ministries of health, even here in Kenya. We work very well with them, and patients and communities. This is our strength, and academia. So partners are our strength, and I always say this. Our CEO always keeps saying, without our partners, DNDi is nothing, and this is true. Our strength is in our partners. Next slide. Mention one of the pillars of DNDi, which I think is relevant, because we are talking really from a low middle income country, and so one of the pillars is strengthening existing capacities in low middle income countries. You can imagine when you start to develop treatments and you're working in low middle income countries, some countries have no expertise, others have some expertise. So one has to really spend time in building capacity to be able to do any research at all. So DNDi over the years has put in a lot of resources and worked with very many partners, and collaborating with more than a third of the partners I've said are from low middle income countries, and building capacity to be able to do clinical trials at international standards. And so the strategy then was to have disease-specific platforms that would then get everybody together as members of this platform and do the research collectively, and therefore be able to quickly recognize what capacities are needed, what is lacking, to be able to do the clinical trials that we have done. So these are examples of the 5 disease platforms that DNDi is involved in. The heart platform, there is a Chagas, the sleep, the red leash, and the filaria platform. So these are critical and crucial in the work that we do. And really we also work together with the ministries of health and help strengthening the health systems and structures. Next slide, please. So I will take one platform from the 5 and just give you a flavor of what these platforms look like or what they're supposed to do. So the one I'm really associated with is the Leishmaniasis East Africa platform, and this was created in 2003 in Sudan. And it is really a clinical research platform that brings together experts from Leishmaniasis endemic African countries to facilitate clinical testing and improved access to better treatments for Leishmaniasis in the region. And it is in the 4 countries, Sudan, Ethiopia, Kenya, and Uganda. And within those countries, the institutions, like each country can bring in the institutions that are working in Leishmaniasis, research institutions, universities, and then ministries of health, and you can read from the slide. We have at least 6 clinical trial sites currently from these countries. 2 from each. We also have 2 from Kenya, but one discontinued, so we have one trial site in Kenya. Next slide, please. So this platform helps in bringing the clinical trials and working closely with DNDi and delivering treatments or innovations that are required. So this is Africa, and what is DNDi doing in Africa? And so DNDi has 3 offices in Africa, as I said before, in Nairobi office, Kinshasa, and Cape Town. And there are specificities to the offices. Most of the sleeping sickness work is done in Kinshasa, and the Cape Town office is mainly partnering with the GADP, Global Antibiotic Research and Development Partnership Organization, together with us, and working on antimicrobial resistance and also on pediatric HIV clinical trials. The Nairobi office is more diverse. We are working on Leishmaniasis, mycetoma, pediatric HIV, and also some antimicrobial resistance work. Next slide. So let us take some diseases. I will take 3 diseases and take you through these diseases so that you can appreciate the suffering, the neglect of this community, so the people that live with the disease. So if we start with the sleeping sickness forms, there's the Gambiasis strain and the Rhodesiasis strain. One of them will give you the brain gets involved, and very serious illness. So 65% of all sleeping sickness cases actually are within the DRC, and that's where our office is. Next slide, please. So if we talk more details, and I try not to use big words as possible, so sleeping sickness is really transmitted by a bite of an infected tsetse fly. And without treatment, the disease is fatal. As I said before, 36 sub-African countries, most of the people have been exposed to sleeping sickness, because most of these people are just, an average, daily average human being. They're just, working in their fields, fishing, or just hunting, or just doing ordinary work, and they encounter the the tsetse fly, and they end up with a sleeping sickness. So for decades, the only treatment available for sleeping sickness was malasoprol, which is an arsenic compound, and it killed 1 in 20 people that it was given to. Next slide, please. So this is the journey that we have seen as DNDi, our contribution to sleeping sickness, and now sustaining, wanting to develop treatment that will sustain elimination. So 15 years ago, as I said, malasoprol was the drug of choice, and it killed 1 in 20 patients. And the patients, they really describe this treatment as feeling like fire in the veins. Can you imagine fire in your veins? It just makes your head even want to burst. So this is how these patients were feeling, but there was no alternative. They had to take this treatment. And then in 2009, we DNDi introduced NECT. NECT is a combination of 2 treatments, and it's effective, improved treatment for patients with sleeping sickness. And as I said, we don't work alone, and we have companies there that were working with us. You can just read it on the slide. So in 2018, then we had this ceiling-breaking innovation that, again, we didn't develop alone, but with partners. And this is a first oral treatment for sleeping sickness. And you just give a tablet, 1 tablet per day for 10 days. And wow, this really has changed the way the management of African sleeping sickness is done. and the treatment is already was already approved by the European Medicine Agency, and also the local Ministry of Health in DRC has approved this for treatment for sleeping sickness. So now in 2022, we are hoping that we will bring another compound, another drug, another treatment called acosiborole, and it's one tablet, one dose to cure the sleeping sickness. What a revolution, what an innovation. So I'm waiting for that day when it comes, because this will be really a big moment, because as you know, the sleeping sickness, we are on the road to elimination. We are now on the last mile. So if we, DNDi together with partners, introduce acosiborole, I think this will just put the sleeping sickness to bed. So I am looking